Good morning, all. I am Dr. Priyanka TG, doing my third year post graduation in the Department of Periodontology. I'm here to talk about the interdisciplinary case based analysis involving an endoperio lesion. So, the agenda of this presentation will be I'll be talking about what is endoperio lesion, its classification, pathways of communication, diagnosis, management, and case evaluation. So, what is endoperio lesion? As we all know, it is the endodontic periodontal lesion that involves both the endodontium as well as the pulpal tissue, and it can either involve them in a separate manner or in a combined manner. Classification of endoperio lesion. Simon's classification in 1972, where there are 5 types, type 1 being the primary endodontic lesion, type 2 being the primary endodontic and secondary periodontal lesion, type 3 being the primary periodontal lesion, type 4 being the primary periodontal and secondary endodontic lesion, and type 5 being the true combined lesion. So this is a picture showing all the 5 types. So the infection can spread either from the pulpal tissue to the periodontal tissue or vice versa through the apical foraminas, axillary foraminas, lateral canals, as well as through the furcation area. Second one being the Grossman's classification in 1988, where there are 3 types. Type 1 that requires only endodontic treatment, type 2 that requires only periodontal treatment, and type 3 that requires a combined endodontic periodontal treatment. Coming to the pathways of communication between the pulp and periodontium. So one that is in developmental in origin, as you can see in the picture A, where it is marked in red, the apical foramina, the larger one, and the smaller one are the axillary foraminas. In B, marked in blue, the accessory canals. Then the cervical enamel projection extending in the furcal area, as you can appreciate, and the cervical enamel pearl, as well as a communication in the furcal area. Other pathways of communication include the dentinal tubules, which can be exposed in case of cemental wear or a root caries and act as a pathway between the pulp and periodontal tissue. Second one being the perforation, which can be iatrogenic during the root canal treatment or caused due to root resorption or a dental caries. So this can also cause a spread of infection from pulp to the periodontium. Third one being the fracture of the tooth, both the vertical and horizontal fractures can be a causative factor. Coming to the diagnosis and management of endoperio lesion. So to diagnose an endodontic periodontal lesion, you have to classify it either to be those only with an endodontic lesion or those with a periodontal lesion or a true combined lesion. Etiological factors and contributing factors can also add to the diagnosis of the lesion. Etiological factor being the bacterial and viral infection or microbiota in the root canal or the periodontium and the host reaction to it, and contributing factors such as the patient pulp periodontal communication, trauma or iatrogenic root surface damage, as well as the aberrant local morphology or a poorly contoured restoration. If it's an endodontic lesion or a periodontal lesion, first determine the prognosis. If it's hopeless, you go for extraction. If it's only an endodontic lesion, then you can go ahead with the endodontic treatment followed by restoration and review the patient. If it's a periodontal lesion alone, initially go for a non-surgical periodontal treatment and then review the patient. If required, further you can go for either resective or regenerative therapy, review and then put the patient under supportive periodontal care. If it's a true combined lesion, then if it's a poor prognosis, go for extraction. If not, go initially with the endodontic treatment and also reinforce the patient to maintain a good oral hygiene, and along with treatment of any perforation, root resorption or a poor restoration needs to be corrected, followed by reviewing the patient and taking up for the periodontal treatment. First, initially non-surgical periodontal therapy will be done, followed by determination of any osseous defects, aberrant local morphology or root damage. If present, then go ahead with the open flap therapy, where a resective or regenerative or combined approach can be carried out, followed by review and putting the patient under supportive periodontal care. So coming to the case evaluation, case summary: 36-year-old male complains of sensitivity and pain in the upper left back tooth for past 2 weeks. No relevant medical history reported. History of root canal treatment done before 2 years. Preoperative assessment reveals 6 mm of probing pocket depth on the distobuccal aspect of 2-6 and 7 mm on the mesiobuccal aspect of 2-6 with a grade 1 mobility. Preoperative radiograph reveals radiolucency on the furcal area as well as on the mesial aspect of 2-6 and a periodontal ligament space widening on the apical area. Diagnosis was given to be endoperiodontal lesion without root damage, grade 3, according to AAP and EFP 2018, and periodontal prognosis was determined to be fair in 2-6. Treatment was carried out. Initial endodontic therapy was carried out, following which IOPA was taken 2 weeks post-operative, and you can see a very good obturation done. Followed by the patient was put for the periodontal therapy. Initial non-surgical periodontal therapy, scaling root planing was done. Following the review, the patient was taken up for the surgical therapy, and on the day of surgery, local anesthesia was given, followed by elevation of a full thickness mucoperiosteal flap in relation to 2-6, completely curated, and a circumferential defect in relation to 2-6 was determined. So which was treated using bone grafting, and GTR membrane was placed, and a simple interrupted sutures were placed in relation to 2-6. Post-operative assessment was done after 7 days, 3 weeks, and at the end of 1 month, followed by at the end of 3 months. IOPA was taken 3 months post-operative. That reveals a good amount of bone fill in the furcal area as well as in the mesial aspect of 2-6. So these are the 3 radiographs comparing that of the baseline and 2 weeks post endodontic therapy and 3 months post periodontal therapy. So very good obturation with a good surgical therapy using bone grafting and GTR membrane gives a very good bone fill as well as a healed lesion in relation to 2-6. So to conclude, interdisciplinary collaboration gives a very favorable outcome, and proper diagnosis and effective therapy must be selected for appropriate success rate to be achieved. Thank you.